Good morning. Interestingly enough, most of the data I'm presenting now have been already presented by the first two speakers. So I am going to put it all together in a clinical context so that you can use it to apply to your patients. Okay, I have no disclosures. Again, a lot of what I'm saying is based on the 2009 and 2015 ATA guidelines. And as I always do, I'm going to start with a case. 26-year-old female. She's had a total thyroidectomy and a left lateral neck dissection because she had a 3.5 centimeter multifocal, well-differentiated thyroid cancer. It was BRAF V600E positive for mutation, and she had 20 positive lymph nodes in the central and the lateral neck. So her initial staging based on AJCC, as we talked about yesterday, is stage 1 because of her age. Her MESA score is low because it also reflects risk of death. And her ATA is going to be intermediate, and that's because of the positive neck nodes that she has. So again, I saw this yesterday, that if you're under 45 years old, as this patient is, you're a stage 1 patient with the exception of having distant disease. So part of the observational studies that happened between the first two guidelines that changed how we stage patients is basically microscopic extrathyroidal extension, microscopic nodes, and number of nodes less than 5 does not appear to be a high-risk element, and therefore it has changed how we stratify those patients with those conditions. So you saw this again yesterday, showing that in the red, that if you use the risk of death on the AJCC staging, that it does correlate. The higher the stage, higher the risk of death. But if you look at recurrence, the recurrence is very high in all 4 stages. So therefore, again, AJCC does not predict the risk of recurrence. Now, we went through this yesterday also, that the low risk tends to be encapsulated single cancer inside the thyroid, no invasion, no nodes, no vascular invasion, not a large number of lymph nodes. Intermediate has microscopic extrathyroid extension, cervical lymph nodes that doesn't differentiate between central and lateral, aggressive histology, and lymphovascular invasion, plus more than 5 positive lymph nodes that are relatively small, less than 3 centimeters. High risk is going to be macroscopic or gross extrathyroidal extension, incomplete tumor resection, distant metastases, lymph nodes that are very large, larger than 3 centimeters, and those patients who have the inappropriate thyroglobulin 4 to 6 weeks after surgery, suggesting that there's still persistent disease. I saw this yesterday. I actually heard a comment, so I need to comment more about it. So if you look at, from Dr. Weisman's studies, if you look at the ATA risk low, intermediate, and high, that the risk of recurrence goes up. So 13% in the low risk, 36% in the high, intermediate risk, and 68% in the high risk. And I sort of heard a comment, how could low-risk patients have a 13% risk of recurrence? Well, the difference is that we're talking about the difference between biochemical incomplete response versus structural. So the vast majority of the low-risk patients have, after treatment, eventually become, you cannot find the disease. A small percentage is biochemical, and a very few patients have structural disease. So most of the patients in ATA risk 1, the 13% who have persistent disease, are the people with biochemical disease, not structural disease. As you go to the ATA intermediate, it almost becomes equal. The people with biochemical only evidence of disease, and the people with actual structural evidence of disease, and then obviously when you get to the high risk, the numbers of people with structural disease outweighs the number with biochemical. So when we talk about recurrence, we're not simply talking about all groups. It's really made up of 2 separate people. The biochemical incomplete, which we are increasing numbers very quickly. As we heard, the thyroglobulin assays have become so sensitive now. We're down to 0.1. We used to be at 2 not that long ago, that all of a sudden we are developing people with persistent disease who we would have called cured 5 or 10 years ago. And then the second group, which is of course the more worrisome group for survival, is the people with structural disease. This is actually a more complicated staging system that the ATA has put together. What I have on the previous slides was sort of a condensed version, and it's worthwhile for you to take a look at this. And I actually, again, have told my fellows you should Xerox it and keep it at your desk, because it really goes through in a very granular way to tell you what they think or what they can predict the risk of recurrence is. So for our patient, she was an intermediate risk because she had more than 5 positive lymph nodes. But then if I look at this list of increasing risks of recurrence, she's actually up here. She actually had extranodal extension and more than 3 lymph nodes involved. So she's actually, even though she's intermediate, she's sort of high up on that intermediate list. Now I just want to point out to you in the very bottom, so if you have an intrathyroidal, less than 4 centimeter, BRAF wild type, the risk of recurrence is 1 to 2%. So again, we sort of get worried when patients have a 2.5 centimeter nodule or a 3 centimeter nodule, but in fact, up to 4 centimeters, the risk of recurrence, wild type BRAF, intrathyroidal, no extension, is actually quite low. So this is worthwhile looking at it because this is the majority of the patients that we have. Intrathyroidal, unifocal, micropapillary, even if it's BRAF mutated, intrathyroidal encapsulated follicular variant of papillary, that's what the subtype of cancer we were talking about yesterday, is that the risk of recurrence is very low, and then unifocal micropapillary carcinoma. So this is something that's really practical. You can look at it and say, all right, this is my patient, this is what they have, and this is what we anticipate the risk of recurrence is going to be. Okay, so again, this is the same patient we looked at. So we, based on these estimates, we think her risk of death is extremely low, less than 1%. But her risk of recurrent or persistent disease is in around the 40% range. Now, most of it's going to be biochemical, although there is a certain fraction, probably about 20%, which will be structural disease. So we've talked about this before, so we've now had a risk assessment of that patient after surgery. We're now going to do a treatment plan, and because she has an intermediate risk of recurrence that's pretty high, she is someone who's I'm going to give radioactive iodine to, and now I have to figure out a follow-up strategy. After I do that follow-up strategy, I'm going to assess how she responds to that to that therapy, and then we're going to go around in the circle forever. So you're going to look at this risk assessment every time you see a patient. Okay, so how can we tell what the risk is? And actually this was covered beautifully in the prior talk, but let me show you my version of it. So if you look at patients who either have a single thyroglobulin, that's the A column, those people who had a thyroglobulin greater than 10 are the people with the highest risk of recurrence. So the recurrent patients are in orange, and then NED, the non-detectable tumor, if there's any, is in blue. On the other hand, if you have patients who have a rising thyroglobulin over time, the vast majority of these, you're going to find structural disease. What I find very interesting is that in most patients, even if their TGs are above 10 here, and they're stable or falling, you won't find disease. And that's what I tell my patients who come in with a TG that's sitting at 5, and we've done a CT scan, we've done a neck ultrasound, we can't find anything. I tell them, you're this category of patient. You have low-level persistent thyroid cancer, probably in a lymph node someplace in your neck. I can't find it, it's not big enough to hurt you, and we're gonna follow you. And if in fact your thyroglobulin stays stable, and what they usually does is trickle down over time, your risk that I'm going to find structural tumor that's going to hurt you is extremely small. That usually makes patients feel a little more comfortable with having persistent disease, and after you've done this for about 5 or 10 years, they don't care. They're very used to having a persistent thyroglobulin. But this is important. So it's what the thyroglobulin is doing over time is a critical element to determine if they're going to have recurrence. So this is a very old article from Clusa and Mazzafari, very similar to what you just heard before. So that in patients who've had thyroidectomy, radioactive iodine, and then they've done common human TSH stimulated thyroglobulin at 1 year, they said, what is the risk of recurrence over 3 to 5 years? In the group that had in this days, the highest TG was 0.5. So had TGs that were less than 0.5, the risk of recurrence over that 3 to 5 years was only about 1.6%. If you're in the intermediate group, 0.6 to 0.2 was 5.5%, and greater than 2 was 80%. So a lot of people wonder where that 2 comes from. This is the study that it comes from, so that when we talk about a stimulated TG greater than 2 being at high risk for recurrence, this is derived from Dr. Mazzafari's study. So again, if you have a patient and you have a baseline TG that's low and you stimulate it and it's still low, that basically you just need to do a periodic, you consider doing a periodic thyroid hormone suppressed TG. So you don't need to re-stimulate that patient. On the other hand, if you have the patient that stimulates between measurable 0.1 now and 2, you're going to be a little more aggressive. You're going to do a periodic, maybe stimulated TG, but in the view of the supersensitive TGs now, most of the time I just watch these patients and I don't repeat the stimulated TG. On the other hand, if it goes above 2, that's the patient who you're actually going to do a prompt evaluation. The first stage is always going to be a CT of the neck and chest. Generally, these patients aren't iodine avid. If I have already had a negative whole body scan, I won't repeat it, okay? Because it is very, very rare that a recurrence will suddenly become iodine avid. So I would start with a usual ultrasound CT of the neck and chest, but the one other caveat is that the TG is really high, so it really stimulates, instead of to 3, stimulates the 15, so above 10, you might consider doing a PET CT scan. Generally, where do we get 10 from? 10 is in part from the regulations in the United States. Most insurance companies will not allow us to do a PET CT unless the thyroglobulin is above 10. And I don't know who picked that number. But in general, there's a good rule of thumb. If you do PET scans on these lower thyroglobulin patients, usually it's going to be negative. You need someone with pretty significant bulky disease in order to find it on a PET scan. Okay, going back to our patient. So 6 months later, she comes back in, her ultrasound is negative, and her TG on suppression is 0.6. So it's not 0, but it's pretty early on. It could continue to fall, and that typically is what happens with a lot of patients. But instead, when she comes back, in 12 months, her neck ultrasound is still negative, but her TG is now 0.6. So this is the sort of patient who I get worried about. The TG is not very high, but it's rising. At this point, 6 to 12 months after therapy, it's usually continuing to eke down over time. And then we did a stimulated, and a stimulated to 5. Okay, so you've seen this already. I'm just going to go through it again because it's always hard to remember everything when you're seeing it up on the slides, is that we now look at the patient and assess what their response to therapy is if they've had thyroidectomy and radioactive iodine. And in this particular case, an excellent response would be negative imaging, and almost that means really a negative ultrasound. A thyroid hormone suppressed TG of less than 0.2, or a TSH stimulated TG that's less than 1. The clinical outcomes as anticipated is that person is going to have a 1 to 4% recurrence rate, which is really in the bottom of that risk. I don't think we can ever actually make anyone recur less than 1 to 2%, so that's a very low risk, and virtually no risk of death. And if you see this, then your response to that is going to say, you're good. We're going to decrease the frequency of follow-up, we're going to decrease the TSH suppression, and this is the person who you're going to ask to release their TSH to 0.5 to 2. Now, on the other hand, intermediate is a non-specific imaging. If you do a whole body scan, it's just sort of faint uptake in the thyroid bed. Your thyroid hormone suppressed TSH is detectable but less than 1, and the stimulated, if you do it, is less than 10. Or if you have a thyroglobulin antibody, it's stable or declining. That's sort of an indeterminate response. About 20% of those patients will actually progress and have structural disease, but the other 80% of patients will resolve over time. So you don't know where your patient's going to be except for following them over time. So you can continue to observe until something comes more suspicious, or if or they resolve. And in this case, you're going to keep their TSH a little more suppressed, like 0.1 to 0.5. Biochemical incomplete then is a little bit worse. So now their suppressed their TSH suppressed thyroglobulins now above 1, or if you stimulate it, it's going to be above 10, or they have an anti-thyroglobulin antibody that's rising. So all of that says that there's biochemical evidence of persistent disease. Interesting, about a third will go to NED. So a third, not all of those patients progress to structural disease. A lot of those patients will just slowly go down and become NED. 20% will become NED if you find the disease and you remove it, and then 20% will go on to structural disease. But the risk of death is still quite low, and that's important to realize. So you're going to continue to watch this person. You're going to watch them perhaps a little more frequently. So maybe every 6 months you're going to measure things. And then you're going to keep your TSH, again, not completely suppressed, but somewhere in the 0.1 to 0.5 range. The worst one is going to be the structurally incomplete. You're going to see either a structural entity that looks like recurrent disease, or you can have radioactive iodine uptake into a metastatic disease. 50 to 80% will continue to have disease despite therapy. And the death rate now becomes higher, about 11% in patients with local regional nodes, and maybe as high as 50% in patients with distant metastatic disease. And the treatment is really variable. It depends on where the tumor is. If it's in a bone, you might radiate it. If it's in the lungs, you're going to watch it. It depends if it's hypermetabolic or not. So it's really hard to tell you exactly what to do, but you're going to watch them much more carefully, perhaps every 3 to 4 months. And in this particular case, you are going to keep the TSH suppressed. And I agree, suppressed is less than 0.1, so if you have a measurable TSH and it's less than 0.1, that's perfectly fine. Okay, let's go back to our patient. So after 6 months, she has a TG of 0.6, so it's measurable but less than 1. So she has an indeterminate response, and my response to that is this: instead of seeing her in a year, I'm going to see her in 6 months, and I'm also going to keep her TSH a little bit on the low side. On the other hand, after 12 months, her ultrasound's still negative. We do a 1-year stimulated whole body scan, and it's negative. But now her TG is up to 1.8. Her stimulated is 10. And now we have to upgrade her to a biochemical incomplete response. And what do we do based on that? Now we do more imaging. We do a CT scan of the neck and chest. We follow up in 6 months, and we definitely will keep her TSH in the 0.1 to 0.45 range. So this is what we're doing, and you're already doing it. It's an iteration of the same thing. We assess the risk, we form a treatment plan, we follow them up at some rate dependent on their risk, and then we say, what is their response to therapy? Oops, let's see. I'm sorry, I'm doing the wrong thing. So this patient's risk for recurrence and how we evaluate her has changed over time. When she originally had her surgery, she was an intermediate risk patient, and the initial therapy then led us to do not only the thyroidectomy, but radioactive iodine disease. The assessment of her response to therapy changed. So in the beginning, she had an indeterminate response because her thyroglobulin did not go to very low, and her stimulated thyroglobulin was less than 10, and that led us to do thyroid ultrasounds and stimulated TGs. On the other hand, when she progressed and her TG was greater than 1, we will do the ultrasound and the thyroid hormone suppressed TG more often, perhaps every 4 to 6 months, and we're going to keep her TSH lower. And then finally, when she became a biochemical incomplete response, we're going to do more. Then we're going to do a CT scan of the neck and chest. If her stimulated TG was higher than 10, I would do a PET CT, and then I would keep her TSH below 0.1, and would follow her probably every 4 to 5 months. So the ATA guidelines recognize factors that increase the risk of recurrence, and I won't read the list because we've talked about it so many times already. The risk assessment is not done once. It's something that you have to do every time you see a patient. And I just wanted to show you, whoops, I keep doing that. What I actually do. I have this template for my note, and every patient I see with thyroid cancer, I put it in again. So oftentimes I don't have to rewrite it because it's going to be what was the AJC stage and what year were they diagnosed? What was their initial ATA risk? What is their current risk today? What do I think the risk is today? I'm going to assess the response. So is it excellent, indeterminate, biochemical incomplete, structural incomplete? And then I have a plan. So when I look at that, every time I see a patient, my next plan will be keep TSH, 0.1 to 0.5, repeat stimulated thyroglobulin in 6 months. And that way I can keep track of what I'm doing with a patient every time I see them. So I want to thank you again for your attention. I forgot to tell you that the Endocrine Society meetings in Boston, you can come and ride our swan boats and see our Make Way for Ducklings and come to Fenway Park. We need 2 rainbows this year to do well in the World Series. So thank you very much.